I'm very excited to introduce and welcome Dr. Allexa Hammond this morning. She received her undergraduate degree in biochemistry and cell biology from Rice University in Houston before completing medical school at Baylor College of Medicine and also in Houston, Texas. She went on to complete her residency in internal medicine at UT Southwestern in Dallas, and then cardiovascular disease fellowship training at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. Dr. Hammond has a special interest in a field that is important to all of us here, the growing field known as cardio-obstetrics, providing care for those who are at risk of developing cardiovascular conditions, those who have known cardiovascular conditions through their preconception, pregnancy, and postpartum journeys. So welcome, Dr. Hammond, this morning. Thank you for joining us.
Thank you so much. I'm really happy to be here, and thank you so much for the invitation and the warm welcome. So yeah, my name is Allexa Hammond. I'm a non-invasive cardiologist and clinical assistant professor here at the University of Wisconsin, and hoping to share the next hour with everyone, really talking about an overview, all-encompassing overview as much as we can in the next hour on this emerging field known as cardio-obstetrics, at least from my perspective or a cardiologist perspective. So we will get started, and I do not have any disclosures. Okay. So 4 objectives that I'm hoping to establish today. So as you can see, first objective, we'll discuss the main drivers which have contributed to the establishment and growth of the cardio-obstetrics field. We'll define the specific patient population evaluated and managed by providers within the cardio-obstetrics field. We'll explain how a cardio-obstetrics program can serve as a catalyst in promoting advocacy for patient populations most vulnerable to succumbing to maternal morbidity and mortality. And we'll also describe how listeners today can become active advocates for at-risk individuals through the preconception, pregnancy, and postpartum phases of care. So I kind of split my presentation into a few different parts, and maybe because I'm a bookworm, but I'll have to start with a brief prologue to begin the presentation. So I think it would be helpful to kind of define what cardio-obstetrics means. So what does it mean? What is the definition at this point? So cardio-obstetrics, at least within cardiovascular medicine, it's a growing subspecialty prioritizing the care of individuals with cardiovascular risk factors or known cardiovascular conditions through their preconception, pregnancy, and postpartum journeys. And if I can bring your attention to the bottom figure, so this is by Dr. Davis, in an article that was published in the Journal of American College of Cardiology earlier this year. And I think this really brings home the point, really summarizing what this field involves and what kind of patients or people we see. So again, it's really a continuum of care through the preconception, through the 4th trimester, and even beyond. In the preconception period, for example, we're often involved in, of course, preconception counseling, especially for those who have a known or established cardiovascular condition. We have several or a few different risk assessment models to help us determine a patient's individual estimated risk, depending on the type of cardiovascular condition they might have during that preconception counseling visit. So to name the most common ones, at least, those would be the CarPreg-2 score, modified WHO. I think those are the 2 most commonly used, but we also have the Zahara score as well. Medication safety is a very important point that we address at each visit, because of course, as we know, a lot of the medications we would use outside of pregnancy can be harmful to baby and to mother during pregnancy. So we do want to make sure that if they're on a cardiac specific medication, those are titrated off in substitution for a medication that is known to have a better safety profile without having any risk for harm to baby. And then, of course, we don't want the individual to go into their pregnancy without optimal control of their baseline cardiovascular conditions, such as hypertension. So that is something that we also really emphasize during that phase of care. And so progressing towards, after the patient conceives and during pregnancy, depending on the specific condition that we are helping to co-manage, we will see them at regular intervals throughout their pregnancy. Dr. Davis mentioned a couple of them here, and we'll mention more in a few slides, but some of the common conditions we help treat include heart failure, arrhythmias, coronary artery disease, ischemia, and structural heart disease. And depending on the condition, again, we might acquire some biomarkers, like a basic natriuretic peptide level, imaging studies such as a transthoracic echocardiogram. And then, of course, she mentions management of hypertension as well. A growing number of our patients do have chronic or essential hypertension coming into their pregnancy. So we do want to make sure their blood pressures are adequately managed, and education is provided on how to check blood pressures and what their blood pressure goals should be during pregnancy. And I will emphasize this many times in this lecture, but interdisciplinary, multidisciplinary care is key within the field of cardio-obstetrics. So that is definitely taking place throughout a patient's pregnancy, multidisciplinary clinical care, and approach to delivery planning. So, and that's also pertinent to the next phase of care, labor and delivery. So again, multidisciplinary plans, which have hopefully already taken place by that point, so that everyone has an idea of their specific roles in the labor and delivery process. Hemodynamic monitoring, if that's needed. For example, for those who are at risk for ventricular or supraventricular arrhythmias, timing of delivery, of course, and then cardiac optimization, so that they're able to go undergo as safe and successful of a delivery course as possible. And then transitioning to the postpartum and 4th trimester phase of care. So again, we do want to pay attention to which medications are safe to use in lactation. We often, as you know, have a couple different medications that are available to us during lactation that were not safe to use in pregnancy that could provide cardioprotective benefit. So we do want to make sure that we reassess those patients in the postpartum phase. Contraception counseling is also important, mental health screening, and of course, transitions to longitudinal long-term care. And I just wanted to highlight again, the multidisciplinary approach is important for this specialty. So I just briefly, we coined this term or the specialty cardio-obstetrics, which of course, it's a combination or mixing of the cardiology and obstetrics providers that take care of these patients. But I really want to say, I think it's a bit of a misnomer. So many other specialties and providers are involved in a patient's care. And as you can see here again by Dr. Davis, this can include primary care physicians, anesthesiology, nursing, social work, pharmacy. And there are a ton of different other subspecialties that are not even included in this diagram. But again, everyone has a role in treating this specific patient population. So it's not just 2 specialties that are involved. Okay, so that was my brief prologue, so we can go into part 1. So the new kid on the block, which we will call cardio-obstetrics. A few questions you might be asking at this point, especially for those who may not have as much familiarity with the field. A few questions might be, why did cardio-obstetrics become yet another subspecialty within cardiovascular medicine? It seems like we're having new specialties pop up every few years or so. So what makes cardio-obstetrics a special subspecialty to consider? Why is this field gaining so much momentum? Do we really need another quote unquote new kid on the block for subspecialty care? And of course, my reason would be, my answer to that question would be yes. But the reasons for the formal foundation and growth of the cardio-obstetrics field largely stem from these statistics, which I'm sure many people have seen at this point. We'll review here. I think these are some striking statistics I wanted to start off with. So I'll bring your attention to the graph on the left first. This graph was from the Commonwealth Fund. But as we unfortunately know, the United States has the highest maternal mortality rate out of all the other high income countries that are listed here in this graph. So, and I like this graph in particular because not only does it kind of really bring home that point that the United States in some regard has almost double the maternal mortality rate compared to the other countries listed here. But then it divides the specific patient populations within the US, and you can start seeing a significant difference in maternal mortality rate depending on the population group you are looking for. So, for example, compared to the US Caucasian or white population, their rate is around 19.1 deaths per 100,000 live births. And compared to the US Black population, that is 55.3 deaths per 100,000 live births. That is particularly striking. And of course, we are all trying to figure out why. We'll talk about health disparities in a moment. And bringing your attention to the graph to the right, this is from the Centers for Disease Control and Prevention, CDC. Looking at trends in pregnancy-related mortality ratios in the United States between 1987 and 2019. And just to bring your attention to the definition of pregnancy-related mortality ratio, this was actually defined by the World Health Organization. So this is the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental cause. So you can pretty much see the general trend. I mean, ever since 1987, there has been a general uptick in the pregnancy-related mortality ratio. And unfortunately, you know, we're hoping at least that we can see a plateau at some point. And of course, our eventual goal is to have this a downtrend, but not only are we not seeing a plateau, we're seeing this ratio rise even further. So we definitely have a lot of work to do to help address the rising maternal mortality rate in our country. So again, from the CDC, now that we know, the maternal mortality rate has been climbing for the past few decades, we do need to look at what is causing, what are the main contributors to pregnancy-related death. And so this is again from the CDC, and this is from 2017 to 2019. And I'll bring your attention to a couple of these, I guess, bars here on the graph. So, of course, talking about cardio-obstetrics, we want to look at cardiology or cardiovascular specific conditions that were the main contributors to maternal death. And so you can see the greatest percentage was attributed to the other cardiovascular conditions at 14.5%. Then you have cardiomyopathy at 12.1%. You have hypertensive disorders of pregnancy at 6.3%. So if you combine those three alone, then you have at least a third, or around a third. And then I would also argue, depending on your subspecialty within cardiology, I would argue that thrombotic pulmonary or other embolism might also kind of bleed into cardiovascular conditions that we treat. For example, where I trained in Pittsburgh, there was a pulmonary embolism team that was made up of an interventional cardiologist, and they would perform clot retrievals of pulmonary emboli, for example. So I do think that, we could argue that this thrombotic pulmonary or other embolism can also be included. But with that said, at least a third of these pregnancy-related deaths are, based on this data, due to a cardiovascular complication. And so based on the maternal mortality review committees, kind of reviewing these cases and outcomes, the thought is 4 in 5 pregnancy-related deaths are preventable. And so that is a huge number. If we can see how many patients that have succumbed to a death, and how many, the proportion of those that are due to a cardiovascular complication, and the vast majority of those cases are preventable. I think that provides some hope that we can help reverse this trend within cardiovascular medicine. And then we'll just transition here to health disparities that I mentioned earlier can be contributing to the differences in maternal outcomes. So again, from CDC, this is from 2018 to 2020. Again, looking at the maternal mortality rates by race and Hispanic origin. And again, just really emphasizing the point that there is a noticeable differences in maternal outcomes or adverse maternal outcomes deaths based on the population group you were looking at. So in 2020, Black women continued to have the highest mortality rates, 55.3 per 100,000 live births. And this rate is 2.9 times the rate for non-Hispanic white women. The rate of maternal mortality rate the rise in maternal mortality rate between 2019 and 2020 was found to be significant for non-Hispanic Black and Hispanic women, but was not found to be significant for whiter Caucasian population. And so I wanted to bring your attention to this study. This is specifically looking at preeclampsia and complications from preeclampsia hospitalization between 2004 and 2019. This was published in the Journal of American College of Cardiology in 2022. This was a retrospective study. The study's aim was to investigate disparities in outcomes of preeclampsia hospitalizations, again, between 2004 to 2019 in the United States, stratified by race and household income, using ICD-9 and ICD-10 codes for retrieval of data, including the estimated median household income based on zip code, delivery hospitalizations, again, including those associated with preeclampsia and eclampsia. The primary study endpoint was inpatient mortality. Secondary endpoints included in-hospital cardiovascular complication, including peripartum cardiomyopathy, acute coronary syndrome, kidney injury, stroke, heart failure, arrhythmias, to name a few. And the figure to the right just gives us an idea of how many cases were identified and how many patients ended up being included in the study, and again, stratified by income. So these were the results. So they looked at the temporal trends of preeclampsia and peripartum cardiomyopathy, again, based on household income. And I wanted to bring your attention to both the low income figure to the left, and then to the high income figure to the right. And just for the color code, Black population is coded red, white populations coded blue, Hispanic brown, Asian or Pacific Islander is green. And on both graphs, really, you can see the general trend. So as the years progressed, you can see a general uptrend in preeclampsia diagnosis, really pertaining to the Black population. You can also see to a lesser degree to the white and Hispanic population as well. And then towards the later years, so there's a general uptrend for pretty much all the population groups, but I think it's most profoundly seen in the Black population here, as you can see in both figures, really. And this, again, is the same trend between the low income and high income groups. This information I thought was actually the most striking in their study. So I'll just summarize some of these results here, and the figure kind of exemplifies these points. So their results showed there was an increased in-hospital mortality seen in Black, Hispanic, and Asian Pacific Islander groups compared to white women across all income groups. Black women had higher odds of cardiovascular complications compared to white women of their corresponding income class. Higher rates of cardiovascular complications were seen in high-income Black women compared to low-income white women. And white women from higher income strata had better outcomes such as mortality, cardiovascular complications compared with white women from lower income groups. But very alarming, this finding was not observed in Black women, and not only was it not observed, Black women from higher income status were actually found to have higher odds of some of these complications that we're looking for in their secondary outcomes, such as acute coronary syndrome and acute kidney injury. very alarming. So the table, or I'll say the section to the, I'm not sure if you can see my clicker, but the section to the left here, again, kind of emphasizes their results. So high income versus low income in both white and Black women. So again, you know, they found that in high income white women versus low income white women, kind of as we would think, you know, for the higher income group, they had a lower odd for mortality, peripartum cardiomyopathy, heart failure, edema, cardiac arrhythmias, or neutral, kind of neutral gain. Compared to high income Black women versus low income Black women, we really didn't see any lower odds for any of these outcomes we were looking for. And in fact, like I said, high income Black women were actually found to have a higher odds for having an acute coronary syndrome, or AKI. And then going towards the rightmost section of the figure here. So high income Black women versus low income white women. High income Black women had a higher odds of peripartum cardiomyopathy, acute coronary syndrome. Like I said, all of these secondary outcomes they were looking for compared to low income white women. And so traditionally, I think some of the reasons people speculated as to why these health disparities exist were thought to be secondary to differences in socioeconomic status or income. But this study really isn't emphasizing that point. It's saying actually, regardless of socioeconomic status, that does not protect Black women, it seems, from having higher rates of complications compared to white women, or compared to a lower income group. So these were some theories or hypotheses expressed by the authors of the study. What might explain these findings? And again, you know, traditionally, I think some of the literature kind of speculated is it due to differences in access to healthcare resources, is it due to differences to income, but really, I think the main point they were trying to bring home here is that structural racism and implicit bias within our healthcare system is likely the primary contributor to these differences in outcomes. So again, and I'll bring this point on later, the importance of making sure that all healthcare providers involved in a patient's care, especially vulnerable populations, are aware that this problem exists, and not only does it exist now, it's existed for, you know, the history of the founding of the United States, and it's definitely contributing to the differences in maternal outcomes that we're seeing. So briefly, you know, we kind of see this more in a national picture, but I did want to bring our attention to our neighborhood, so within the state as well. So this is information from the Wisconsin Department of Health Services. So I'll bring your attention to the left. So this is epidemiological data on maternal outcomes in Wisconsin, maternal mortality between 2006 and 2010. So I'll give you the information based on the national kind of US data. So 16 maternal deaths per 100,000 live birth were seen in the United States. The number of maternal deaths per 100,000 live births was 3.2 times greater in non-Hispanic Black women than non-Hispanic white women. And then this is compared to our state. So 5.9 maternal deaths per 100,000 live births were seen in Wisconsin. And if we left it there, you know, we would see, oh, wow, well, the 5.9 maternal deaths compared to 16 maternal deaths nationally, well, that's actually okay, right? Well, really bringing home the point that even though there are lesser maternal deaths seen during this time period, the health disparities actually seen in our state is much more profound than what we saw nationally. So the last point I think matters. So the number of maternal deaths per 100,000 live births was 5 times greater in non-Hispanic Black women than non-Hispanic white women in our state. So again, really re-emphasizing that point that there are extreme differences in maternal outcomes nationally, but also within our state here. Going to the right, we have some more recent data between 2016 and 2017, the Wisconsin Maternal Mortality Report. Again, emphasizing the point. So they saw 24% of live births were non-Hispanic, Black, Asian, Hispanic, Indigenous. But 42% of pregnancy-related deaths were non-Hispanic, Black, Asian, Hispanic. So that's almost double the amount of the patient population that we, I guess, of the data acquired for live births. So there's a huge, again, huge disparity that exists in regards to adverse maternal outcomes in at-risk vulnerable populations within our state. So the last point I want to bring home, so if that was not enough, it was quite a mouthful, but definitely worth considering. So all of those factors certainly help to grow the cardio-obstetrics field and gain its momentum. But we're also seeing, we have been seeing for the past at least few or several years or so, and greater recognition for certain pregnancy-related complications related to increased future risk for cardiovascular disease down the road. And so briefly, I'll bring your attention to this study. It's a Swedish study. Around 2 million women were involved, and they tracked these women from the date of their first pregnancy to either death or end of follow-up. The mean age of patients enrolled in this study was around their mid-20s. Median follow-up was also around at least 22 years. And they looked at pregnancy-related complications, which they specified as gestational hypertension, preeclampsia or eclampsia, low birth weight, small for gestational age, to name a few. And they not only looked at the incidence of these pregnancy-related complications, of which 19% of those patients actually developed those conditions, so quite a high number. But they also wanted to see, based on those pregnancy-related complications, when was the time point that they would succumb to a cardiovascular condition such as ischemic heart disease, ischemic stroke, and peripheral arterial disease. And their study showed that all pregnancy-related complications were associated with a higher risk of a pregnancy-related complications were associated with a higher risk of a cardiovascular complication at an earlier age. As I mentioned before, looking at coronary artery disease, for example, peripheral arterial disease and stroke. Those who had preeclampsia or eclampsia had at least a twofold increased risk for succumbing to one of these conditions at an earlier age. And then for small for gestational age and preterm birth, also almost double the risk of cardiovascular mortality. So we are within our specialty, we are starting to recognize that these are factors that we need to take into consideration when we see any of our patients. In fact, one of the in the primary prevention guidelines that were published a couple years ago, preeclampsia is now considered a risk enhancer when considering whether or not to start a cholesterol-lowering medication such as a statin. So we are starting to slowly increase some gain in understanding that these pregnancy complications should not be taken lightly, and these patients do require more aggressive screening for other traditional risk factors for atherosclerotic cardiovascular disease down the road. Okay, so part two. Hopefully I convinced you that the new kid on the block deserves a role within the healthcare system, but what is the cardio-obstetrics provider's clinical role within our larger healthcare system? So this is by Dr. Park. I'll bring your attention to the figure on the left. And we already kind of emphasized this point. So again, we're kind of looking to the continuum of care through preconception, peripartum, and postpartum management. I mentioned a few of the conditions that we can help co-manage. So again, ischemic heart disease, cardiomyopathy, arrhythmias, hypertensive disorders of pregnancy are a few. There are some that were not mentioned in this figure, so I just wanted to bring your attention to kind of what I've added as well to the right. So we cardio-obstetric specialists also manage valvular disease, such as stenotic or regurgitant lesions. If a patient's had a prior valve replacement by a prosthetic or mechanical valve, of course, not only do we want to make sure the valve is looking okay, but anticoagulation certainly plays a role in making sure they're on the right dose and on the right type of medication that are safe for them and baby during their pregnancy. Infective endocarditis is also something that we can help co-manage as well. They mentioned ischemic heart disease in the figure, but I did want to bring your specific focus to spontaneous coronary artery dissection, which we can see in pregnancy, so also known as SCAD. Pulmonary hypertension, aortopathies, which can be managed by our advanced congenital heart disease specialists, pericardial diseases, intracardiac lesions, and so much more. And by so much more, I mean, they didn't really include, again, the adult congenital heart disease specialists, but I would say even traditionally, before this became more of a recognized field, the majority of the patients that were seen often were the congenital patients with underlying structural heart disease. And so that has since expanded as we have since had have more patients with various comorbidities such as hypertension at baseline, chronic hypertension, or arrhythmias, atrial fibrillation. But certainly, I think a separate box should be included in that figure to include the advanced adult congenital heart disease specialists as well. Again, circling that point, that multidisciplinary care is key, especially within cardiology, because as we'll see here, I have a case example that exemplifies the point that multidisciplinary care is crucial for making sure that the patient has the most favorable outcome as possible, both patient, maternal, and fetal outcome. So briefly, looks like we're halfway through, so I do want to bring home this point. So this is a 19-year-old G1P0 female. She had a history of Loeys-Dietz syndrome, past surgical history significant for aortic valve sparing, root replacement in 2014, ascending aortic aneurysm, followed by replacement. And just for your information, if you want to know more, I have the specifics in parentheses there. And patent ductus arteriosus, she had a ligation for in 2014. At this point, she had known moderate aortic insufficiency and aortic stenosis following that root replacement in 2014. And when she conceived, she established care with her OB MFM team and continued follow-up care with her adult congenital heart disease specialist. And she underwent surveillance imaging through her pregnancy via primarily MRA of the aorta and transthoracic echoes. She was already on labetalol, which was continued through her pregnancy. She was also seen by a genetics counselor and anesthesia for delivery planning, and again, had that multidisciplinary discussion sometime in the second trimester for delivery planning. So again, she already had a lot of different healthcare providers involved to make sure that she had the best, most favorable outcome in her care. So I mentioned she underwent a surveillance imaging via MRA aorta. Before we get to that, I did want to bring your attention to the baseline studies, primarily the echo. So the figure, I guess the image to the left is a apical 5-chamber view. So you'll see, again, I'm not sure if you can see my clicker, hopefully you can, but the aortic valve here is in the middle, and you can see that regurgitation. So that red kind of blooming jet into the left ventricle is her aortic insufficiency jet. So we called that moderate. And then I'll bring your attention to the figure to the right. So looking at the degree of aortic stenosis, we usually measure that based on the peak velocity and mean gradient. So here it looks like it's actually more consistent with mild, but based on the aortic valve area, they're getting more moderate, so mild, moderate. Okay, and we can also look at the measurements of the aorta and aortic arch at the site of the repair. So ascending aorta diameter was looking okay. Same thing with the aortic arch and visualized portion of the descending thoracic aorta. Okay, so she got her MRA in the third trimester. And I will kind of scan through the MRI scan here for you, and then I'll kind of bring your attention. I have a still frame that the radiologist was kind enough to point to where the abnormality was, but I'll give this a one-time run through, and then I'll point you to what we found. And again, I'm sorry, I don't know if you see my clicker, but here's the aorta here. Okay, and then here's the still frame. So again, the radiologist who read the study was kind enough to guide us which series had the abnormality. So again, this is the aorta here. And I'm not a radiologist by any means. I don't read these studies. But what I'm thinking he's looking at here is this small little dissection flap. So she was actually found to have a new type B or aortic dissection at this time. She was around 38 weeks gestation. Interestingly, she was hemodynamically stable and did not have any acute features suggestive of that this was more acute in process, but we didn't know the exact duration that this occurred. So again, the patient was asymptomatic. With that said, because it was a newfound dissection, an urgent multidisciplinary discussion took place to have the patient admitted to the university hospital with plans for an urgent C-section the following morning. This is where I think I was introduced to the patient. So once she was admitted to our service, vitals on arrival, she was afebrile, blood pressure was okay, heart rate was okay, respiratory rate 18 breaths per minute, pulse ox 97% of room air. So vitals looked okay. Exam, she wasn't in any acute distress. She had that known systolic ejection murmur in the setting of her aortic stenosis. And her labs were actually pretty good. So troponin was negative, hemoglobin count fine, platelet count fine, kidney function looking okay. And so again, just to really reemphasize the point in how many care providers were involved during her hospitalization, she was admitted to our service, placed on telemetry. The congenital heart disease groups was of course following throughout her hospital course. OB and MFM service examined the patient. Plans were confirmed for a primary C-section the following morning. Vascular surgery was consulted, gave us some parameters for a strict blood pressure and heart rate control, continuing on labetalol. Cardiac anesthesiology service was consulted, and of course, vascular surgery continued to follow through her hospital course. The next morning, she was still hemodynamically stable. She was transported for her C-section, cardiac anesthesia, ended up placing an arterial line for invasive hemodynamic monitoring and general anesthesia. MFM successfully had an urgent C-section performed at 38 weeks, 1 day gestation. And then the patient was transferred to the CT-ICU for close monitoring in the early postpartum period. She started on an esmolol infusion for strict blood pressure and heart rate control, and then pain well controlled with assistance by anesthesia as well. And of course, baby was taken to the NICU. Lactation support was consulted. OB and vascular continued to follow. Vascular, we recommended a CTA aorta in the early postpartum period, which was actually done the following day, and I'll bring your attention here. So you can still see right here, a little flap, but they called this a stable finding. And they also just remeasured the ascending aorta, which actually looked like it increased a bit in size compared to the echo. Not too much to require an urgent intervention, but it was around 40 millimeters at that time now. Okay. So the next day, esmolol was successfully weaned off. She was transitioned back to labetalol, then she was transferred back to our service. Started on aspirin per vascular recommendations and continued on labetalol. And then just to make sure her, recheck her aortic valve and echo was also done at that time too. I'll bring your attention now here. So the velocities through the aortic valve seem to have increased. Just a touch, but sorry. They did increase, still consistent with mild, moderate. And then we will play this video here. So you can actually see, interestingly, kind of as expected with her condition, you can see some prolapse of the one of the coronary cusps here, the aortic valve. And then I will bring your attention to the bottom table here. So again, you can see that regurgitant jet. This time it's kind of that flash of blue. So stable findings for the most part for involving the hemodynamics with her aortic valve. Okay. So CT surgery was also consulted to discuss the timing of aortic repair. And CT surgery recommended outpatient follow-up 2 weeks after discharge with the planned aortic repair 6 to 8 weeks postpartum once her hemodynamic fluctuations kind of settled out a little bit. So discharge planning, therefore, was underway. She remained hemodynamically stable, just to allow for further titration of labetalol dosing. Once we got a steady dose, she was discharged on 300 labetalol twice a day, aspirin. A social work assisted with acquiring an electric breast pump and blood pressure monitor for home use. And she had planned to follow up with her OB team, congenital cardiology, and CT surgery. So I would say that's a successful discharge, and she did not have any immediate postpartum or perioperative adverse outcomes, in spite of being a high risk, I would say high risk case. So again, case in point, it really does take a village. Everything I highlighted in yellow, I could find were providers that were involved in her care. So really everyone to the left here, all these experts here were involved. And then strikingly, and this is why I thought this was a great case as an example, at least half or over half of the represented fields here were involved in this patient's immediate care, which I think was incredible. So it really does take a village, much more than what cardio-obstetrics, just, two specialties. It takes so many more providers to make sure a patient has a successful outcome. So really key. Okay, so next part, all hands on deck. So how can we as a healthcare community work together to combat the rising maternal mortality rate? So I have a couple of, I feel like a lawyer here trying to express my case for why this a cardio-obstetrics program is needed. But I think by building a formal cardio-obstetrics program, we would have a dedicated space for all stakeholders in maternal health to actively address the factors contributing to our rising maternal morbidity and mortality rates. And it's just not what I think. It's really what's been emphasized and pointed out many times over in the recent years by various stakeholders within the American College of Cardiology as well, and other subspecialties such as maternal fetal medicine. Okay, so a formal cardio-obstetrics program can serve as a catalyst for positively impacting the delivery of maternal health care through prioritizing. And there's a few points here, but briefly, guideline-directed clinical care is certainly helpful, so that, and these are kind of associated to the figure to the right, but by clinical care, I mean the provision of multidisciplinary care, such as a dedicated cardio-obstetrics clinic, multidisciplinary meetings, again, through the pregnancy course, delivery planning, a multidisciplinary approach. And then also expanding our fund of knowledge is also crucial. We'll get to that in a moment, but there are certainly some gaps in knowledge, at least within our side, the cardiology side, where I think having more exposure for the trainees, medical trainees, and anyone who's interested, healthcare providers, to gain further clinical exposure and access to educational materials to help increase our fund of knowledge. And then, of course, research. As we all know, traditionally, women, and especially pregnant women, have not been included in trials. And we're still struggling with this, though it seems like this has been more recognized as a problem, since there's so much we still do not know in regards to how to best treat these patients. We're just now starting to get some guidelines out there, and the European Society of Cardiology actually has a pregnancy-specific guideline, which is a nice reference. But we still have some ways to go in seeing how we can better improve the care we provide to our patients. Community outreach initiatives are also important. A couple in mind include health fairs and educational seminars, quality improvement initiatives within our healthcare system, such as multidisciplinary case review discussions. I mentioned the maternal mortality review committees. So those are extremely helpful. And then, of course, advocating for the patients we treat. A patient may come to us, or an individual might come to us and express their concerns, but we're really the providers that should listen and take those concerns seriously. And unfortunately, this has been documented that a lot of patients, especially vulnerable patient populations, do not feel heard. And so we do need to start taking that into account too. So again, this is kind of more towards, the cardiology side, but Dr. Bello published a study in 2022 in the Journal of American Heart Association, specifically looking at the provider's comfort levels within cardiovascular medicine in treating pregnant patients. And again, with some striking findings. So about 500 participants were included, and they kind of assessed a person's confidence level in a survey. And so the survey participants included physicians, cardiovascular fellows, and cardiovascular team members, which included nurse practitioners, pharmacists, physician assistants, and nurses. And so I'll bring your attention to the first figure here. So from a scale of 1 to 5, or otherwise no response, 5 being extremely confident, 1 being not at all confident, they kind of have a bar graph here listing the percentage of people, whether or not they're an MD, fellow or part of the cardiovascular care team, how confident they are in the provision of a certain, care, whether or not it's providing a medication that is specific to a lactating patient, managing cardiovascular disease in a pregnant patient, or prescribing a cardiology-related medication to a pregnant patient. The general trend is that what they call the MDs, so the physicians, seem to have the most confidence in treating, prescribing these medications or managing a patient with a cardiovascular condition. Fellows seem to have somewhat less confidence than their counterparts, than their attendings or physicians. And then really strikingly, so the part of the care team members, the cardiovascular team members, really seem to have the greatest percentage of not at all confident when treating pregnant individuals with cardiovascular complications or conditions, or prescribing a medication in pregnancy or during breastfeeding. And then again, kind of re-emphasizing the point that we do have some work to do to help bridge these gaps in knowledge. But this is gaps in comfort level for the treatment of cardiovascular disease in pregnant versus non-pregnant adults. So they kind of, to get this information, they kind of compared what a person's comfort level for the treatment of these conditions in non-pregnant adults compared to their comfort level for treatment in pregnant individuals. And so again, we would see that for the MD or physicians, they seem to have the least gap in comfort level. So they seem to kind of be in the blue there, but compared to fellows and CV team members, they seem to have the greatest discomfort in treating pregnant patients compared to non-pregnant patients. And I think that's most particularly seen in the cardiovascular care team. So again, nurse practitioners would be part of that group. I have a couple more statistics that, again, it all brings home the point. But 23% of cardiovascular fellows reported they have not evaluated a patient or lactating patient over the course of their fellowship to date. And again, this study was recent. This was in the past couple years or so. 83% of fellows reported having no formal training in cardio-obstetrics. 29% of practicing cardiologists received cardio-obstetrics didactics during training, so that is a dismally low number. 52% of practicing cardiologists reported feeling very or extremely confident in managing cardiovascular disease in pregnancy, and 76% of survey respondents reported lacking access to a dedicated cardio-obstetrics team. So again, really emphasizing that there is a certain need for increasing the amount of access to educational and clinical resources to help increase fund of knowledge, not just for people already practicing, but for our trainees that are about to practice in the next few years. So in the short amount of time we have left, I will briefly go over this. This is the last study I was hoping to kind of talk about, but we're wondering, we're pushing for cardio-obstetrics programs nationally. Well, does it really help in reducing maternal adverse outcomes? I think this study kind of helps to answer that question. So this was published in 2020. again, in Jack retrospective, that was a retrospective study assessing maternal outcomes for those cared by a specific cardio-obstetrics program at Columbia in New York City between 2010 and 2019. 306 patients were included in the study, and of note, most of them were enrolled in Medicaid, and the majority of patients included were individuals of color. They classified risk based on the CARPEC-2 score, which I included in the figure to the right. 42.5% of patients had a CARPEC-2 score of at least 4. So, certainly not low risk. They would be considered in the higher risk spectrum for having an adverse cardiovascular outcome. The maternal outcomes assessed included the primary outcome, including cardiovascular readmission at 30, 90, and 1 year. Secondary outcomes included maternal death, needed for LVAD or heart transplant, and fetal demise. And so again, briefly, so the results that they showed, 6 patients, 2%, were readmitted within 30 days, 14 patients were readmitted within 90 days, and 17 patients, so about 6.5%, were admitted after 1 year. And that was considered much lower than anticipated, so they were quite happy with those results. There was 1 pregnancy-related death, 3 required an LVAD, 2 required a heart transplant, and 4 pregnancies resulted in fetal demise. So the bottom line is that based on what they're looking at in their primary outcome, readmission rates were low. So could this be helpful in helping to reduce readmission? And were the maternal outcomes perhaps better than anticipated? So I think more studies are needed in order to help us really solidify how much cardio-obstetrics can benefit our specific patient populations, and particularly our most vulnerable patient populations. But again, I think these are promising results. Okay, so how can we advocate for those most vulnerable to adverse maternal outcomes? I mentioned this briefly before, but I'll just bring your attention to this slide, and I wish I can have, what's kind of cool is that, since the rising maternal mortality rate has become more of a recognized concern in the US, there have been more and more organizations that have been established to help address these outcomes and of course try our best to fix them. I'm really focusing on health disparities and how we can address the potential factors that are contributing to these disparities. So I have a few listed here. So the Preeclampsia Foundation and the Black Mamas Matter Alliance are a couple of more national organizations that one can be more involved in or learn more about. Of course, I think the majority of us have heard about the Hear Her campaign. That's supported or established by the CDC, and really cool resources. So not only just for the patient or the individual who's pregnant, but it's really also a lot of great resources for their loved ones, family members, and healthcare professionals. And I mentioned in the last second point, we should advocate for strategies which are proven to be effective in addressing and correcting implicit bias. Well, within the Hear Her campaign, if you look in the healthcare professional section, there's actually a dedicated subsection that provides resources one can access to help understand, what is implicit bias and how can we know that we have some degree of implicit bias and how to address that bias when we're about to see a patient, so that we can better hear that patient and better treat them and not let our bias undermine the patient's chief complaint or what they're there for. And then, of course, the first point, advocating for change in healthcare policy as well, should be emphasized as well. So again, gaps in insurance is something that in the postpartum period is something that has been known to help serve as a barrier in proper postpartum care and access to healthcare resources. So a lot of work to do, but I do think there's some hope. And again, there's a lot of foundations that exist, and I think more and more are becoming established to help address these concerns. Okay, so in 4 minutes, I think I'll make it in time. So epilogue, moving forward together. I just wanted to bring home this excerpt from Dr. Graves, which I think is kind of summarizing the whole point. I will bring your attention to what I've highlighted. So when we were talking about cardio-obstetrics, we talked a lot, but how can we really bring this discussion to action? Again, just as they emphasize, a multidisciplinary team is crucial. Integrating the complexities of maternal physiology and cardiovascular disease requires that teams involved in cardio-obstetric care respect and learn from each other, which I love that statement, and an environment of learning and information exchange should be embraced. And so since, I'm presenting grand rounds today and I'm from a completely separate department, but I think we do have a lot of shared concerns about the specific patient population. There's certain educational resources I was hoping to share with you today in case anyone is interested in learning more about cardio-obstetrics or already have a foundation for some of the concepts, but just want to learn more.
Yeah.
There's a Cardio Nerds Cardio-Obstetrics series.
Yeah.
That's a podcast anyone can listen to. These are Cardio Nerds is a podcast.
Yeah, I mean, she's no one, but we got her a helper tower, like for the kitchen.
Whoever's on, yeah, thanks.
Sorry.
No.
Last slide, I promise. So this is a podcast that really encompasses a lot of different cardiology specific conditions, and it's very educational, goes through different case presentations, and they have different guest lectures for faculty that come in and kind of give their 2 cents on how to best approach the care of these patients. But there's a specific cardio-obstetric specific series within Cardio Nerds that is really helpful in understanding just the foundational concepts and most common conditions that we treat. So I really encourage any listeners who are interested in learning more to look into listening to this podcast. And then also, this is kind of last minute, but this will happen tomorrow. The American College of Cardiology is hosting a course, Cardio-Obstetrics Essentials. That's a virtual course. I believe it starts at 10 o'clock tomorrow morning. But it's pretty much throughout the day. Again, virtual session. You do have to register for it, but I do think registration is still open. So for anyone interested, I listened to this last year and I thought it was very, very helpful. I think last year was the first time that they had this course introduced. So this is the second time around, but I would highly encourage anyone interested to kind of listen in. And with that said, 1 minute to spare. Thank you. Here's my email for anyone interested in reaching out to me, and then I'll just have my references here to share. And thanks again.
Wonderful. Thank you so much. I think we can have time for a question or two.
Hi, Sigor. I just want to say thank you for all the help of your team and everybody else. And I also want to highlight that we couldn't do this not only with MFM, but our ASOC partners are the ones delivering these patients and are really comfortable with all these cardiac patients. And I think that is absolutely key to the success of this, because they are providing vaginal delivery experiences to these very sick women that are really looking to have as much of a normal labor and delivery experience. So thank you all.
Absolutely. And I have to thank my colleagues here too. I mean, certainly we can't, it really does require a village. So I can't emphasize that point any more than I tried to during this conversation, but it really does take a village, and I appreciate everyone's involvement in making sure these patients have the best deserved care that they can possibly achieve.
Wonderful. Thank you so much. You're getting lots of great comments here in the chat, and thank you for leaving your email up there. Really appreciate you coming to talk to us today, and everyone have a great day.
Of course. Thank you so much.